As we discussed last night, the two main themes of our Shabbos experience is going to be mental health on the one hand and end-of-life issues on the other hand. So this room will be discussing end-of-life issues, one of the important topics for in general what we in general in medicine and Klal Yisrael are facing, and the other room is going to be dealing with some mental health. Some families have chosen to split up and have representatives in each room, but otherwise, hopefully, we will be able to at some point share and exchange some of the information. Here in this room this morning, it's my pleasure to invite Rabbi Glatt, and he'll be talking about some of the topics around triage and end-of-life care, and then we'll have a Q&A, as I said. So we're going to be mindful of the time. We're going to end at around 11 o'clock. The two speakers are aware, and we'll try to figure out exactly how that will work out in the morning. Without further ado, Rabbi Glatt.
So thank you very much, Rav Laser, as always. Beautiful putting together on the fly at the very last moment, so kol hakavod. The learning objectives here will be really to talk about a number of complex end-of-life issues, which you'll hopefully have questions on. And one of the most common questions that I get is, can religion and halacha and medicine coexist? And the answer is absolutely. HaKadosh Baruch Hu created the world. HaKadosh Baruch Hu is the author, the editor, the redactor of everything that we do. So therefore, there cannot be, by definition, there cannot be a conflict between science and halacha. Now, sometimes we have to work at it to figure out what HaKadosh Baruch Hu intended us to figure out. But there, by definition, cannot be a conflict. And I always like to tell people that all of these seeming conflicts, well, the Gemara says this and that's ridiculous, sometimes we have to have a little humility, because one of my favorite examples of this is a Gemara that talks about how certain types of genetics are only transmitted on the female side. And there didn't seem to be any explanation of that. And the Gemara says, no, this is only transmitted to the girl children and not to the boy children. That doesn't make sense. The other way around, science understood, but we didn't understand how something could be transmitted only to the girl children. And we laughed at the Gemara, not me, but people laughed at the Gemara and said, what do they know? And then, of course, when we learned about mitochondrial DNA being a component of the mother's egg that isn't DNA from the nucleus, all of a sudden we understood that the Gemara was right and science just didn't know. So there are many times that we have seeming conflicts between what science tells us and what halacha, what Gemara, what Masorah tells us. And before we say that one is wrong, meaning that the halacha is wrong, that our Masorah is wrong, we should have a little bit of humility and say that maybe science doesn't yet fully understand everything. And that's a good introduction to end of life, because end of life is always changing. There are many, many different aspects of end of life that seem to, the mores, the ethics of the world, don't necessarily agree with the halacha. At least secular mores and ethics don't seem to follow sometimes halacha. And the most common shilas I get from doctors are, they want me to do this. Am I allowed to do this? What should I do in this situation? We do training of doctors. We have a Shomer Shabbos residency, for example. And there are shilas that come up all the time. And an educated consumer is the only way that you can be a Shomer Torah Mitzvahs doctor. You have to know what the halacha is, and you have to know to ask shilas. Aseh l'chorav, in my opinion, is the single most important imperative for a Jewish doctor. A person has to have somebody they can ask shilas to. A person has to know what is a shilah, what's not a shilah. Sometimes doctors, if they don't have a sound foundation in halacha, so they don't even know that this is a shilah. What's wrong with doing this? And they don't realize that it could be ritzicha, it could be actual murder, albeit their hearts are in the right places, but if they're doing something that is usur, they're doing something that is usur. So it's critically important, in fact, that they do exist, and I don't have any problems ever with anything that I've read in the Gemara, anything that we have in our Masorah that seems to be contradicted by science. And that includes the common buzz issues like evolution and ontology and phylogeny and all the things that we sometimes try to shy away from in yeshivas, because sometimes the Rabbeim aren't given the adequate scientific and halachic background, and they just like to shy away from stuff and say, no, just ignore all that science stuff. And that ultimately, I think, is a tremendous problem, because when kids grow up, they're no longer going to accept that, well, that's what the Torah says, and that's what science says, and science is wrong. And I think as the children grow up and they question if we don't have the answers for them, so that's far worse than us saying to the children, this is a problem, and this is how the Torah addresses it. So a lot of the end-of-life stuff is based upon the principle of primum non nocere, which is a famous Latin term. I once gave an entire secular talk about the origins of this. It's an interesting discussion where these words were first discussed and used, but that's the bottom line. A physician, by definition, his job is to make patients as best as possible. That doesn't mean to cure them. It doesn't mean to always extend their life to 120. Halavai, that's what we should be able to do. Everybody wants to have a healthy, long life, fully capable, without mental or physical deterioration. A good physician tries to do that to the best of their ability. But we understand our limitations. And the job of a physician is to make the patient at all times as comfortable and as healthy and as, I would say, halachically capable as possible. Rav Shechter Shlita always gave us the example that he would say, what happens if an 18-year-old kid who's a very, very star athlete, Rahman al-Islam, gets into a car accident, he actually used the term a skiing accident, and they tell him he needs to have both of his legs amputated. He has terrible trauma. There's nothing that they could do with reconstruction. He needs to have both of his legs amputated. The kid's alert, oriented, says, nah, if I can't ski, if I can't be a professional basketball player, if I can't be vigorous and athletic, I'd rather die. I forbid you to do the surgery on me. So what's the halacha? So in the time of a base, in the time of a Sanhedrin, they'd strap the kid down, give him anesthesia, and take off his legs because it's pikuach nefashos. He'll live a perfectly happy, healthy life. Just his legs are going to kill him right now because Nebuch, he's had a terrible traumatic incident. But his life is not impacted by that if you do the surgery. If you do what you're supposed to do, the halacha requires a person to save life when the parameters of that saving life fit within the halachic framework. Somebody to lose their legs, Rahman al-Islam, a terrible, terrible, terrible thing, but halacha would say that that person is a absolute chiyuv to go and preserve their life. That's one extreme. The other extreme, which unfortunately I also get many shilas about, is you have a person who has terrible, Rahman al-Islam, lo aleinu, metastatic cancer all over the body, is in terrible pain, and I had such a maisa that it still hurts me very much. The family came crying to me, literally crying to me, that the patient was suffering. He was in agony. And the Rav that they'd asked the Shaila to had said, no, you're obligated to continue to give them fluids. You're obligated to continue to do everything for this patient. The patient had zero medical expectation of having any likelihood of outcome other than death. Nebuch, our skills are quite limited. We all know that. We don't like to tell that to the public, but we know that our skills are sometimes quite limited. And there was absolutely nothing medicine had to offer this person other than that we could keep that person alive in pain for an extra few days. And the person that they'd asked, a very, very bright Talmid Chacham who, knows 99% of the halachos much better than 99% of the people in the world, did not really understand medicine. And Paskin that, you have to give this patient fluids. So they came crying to me. I said, number one, fluids aren't indicated in this patient. You're actually fluid overloading the patient. That's why they're having anasarca, and that's why they're nebuch in such pain, because they were being basically given pain-giving medicine rather than pain relief medicine. The fluids were contraindicated. So that was number one. So there's no chiyuv to give somebody hydration in a situation where the hydration is actually killing them or certainly not helping them. And second of all, this patient was in severe pain that wasn't able to be controlled with appropriate palliative methods. So there is absolutely chiyuv, and the great poskim talk about this, that there is no chiyuv in that situation to prolong death as opposed to prolonging life. And Lanias Dati, that patient was having a huge disfavor done to them by insisting that everything be done. The patient was actually going to be fully coded. That patient was going to be intubated. And I think, Baruch Hashem, I had the ability to step in, and the patient did not have any of those interventions. And I think that this is one of the most critical ideas that we have. And we as physicians are supposed to make people better, spiritually better, physically better, and that doesn't always mean to give them more therapies. And that's triage and end of life. We have to decide what is appropriate medically first, and then does the halacha sanction sometimes halacha allows. There's three possible answers. Halacha says it's mandated. Halacha says it's awesome. Those are the two extremes. Those are sometimes the easiest cases. The gray area in between is where most of the discussion comes, where there are valid differences amongst the great poskim who do understand these issues. I've had the wonderful zechus to speak with some poskim that I'm embarrassed to say sometimes they knew medicine better than I did. They knew the intricacies. I once was discussing with a great gadol a complex obstetrical shaila, and I was amazed how much obstetrics this posek understood and knew. And I'll tell you another time, I was asked to give my opinion to a gadol b'Yisrael on Zika. And I spoke to him, and he said, well, there is a shaila, and he posed it to me as a medical question. I said, oh, I can give you the answer on that. It was a medical question. He says, I wasn't asking you for the medical answer. I was saying that medicine doesn't know the answer to this question. So I was going to give him my opinion. And I said, whoa, he's Yodea Sefer, not only the Svarim that you expect in a base medrash, but he was very, very familiar with the medicine. So those type of poskim, those type of rabbanim, which Baruch Hashem there are plenty of, they're the ones that need to have these shaylas asked to. Because sometimes the default position by many is, do everything. You can't sign a DNR. There are rabbanim out there that say you can't sign a DNR. That's just Keneged HaTorah. That's Keneged the great poskim. So there are, unfortunately, rabbis out there that believe in physician-assisted suicide. You know, they believe that, yeah, well, we have to do mercy killings. We have to do what the patient really wants. And that's also Keneged Halacha. So extremes are very important to be aware of. And that common ground in the middle is critically important to find out where we should be. So I love this slide on the Lubavitcher Rebbe. The Lubavitcher Rebbe Zatzal never liked to refer to hospitals as a base cholim. He called them a base refuah. And that's the way we should view our hospitals. They're a place of healing. Sometimes patients go there to die. But they should always be in a healing, comforting fashion and manner. It's critically important that hospitals be utilized properly. And I just had the schus to send somebody home from the hospital who subsequently passed away. And they died at home without the PEG, the potential intubation, because they hadn't signed the DNR, and the central line that was about to be put in, when I knew medically that there was zero chance that that would make any difference in that person's outcome. There are some times that we have to understand that we are quite limited in our abilities to make a patient better. And because we can do something, yes, we can put in a central line, we can give them vancomycin and Zosyn. We can go and put them on whatever drug du jour we want to give them. This patient could have been on 5 pressors. It wouldn't have made one iota of a difference. Their time, Nebuch, was up. And what we have to do in those situations is make sure that we do what is best for that patient and not what is best from our point of view, what we think should be done because I can do it. And that's why they have to be a Beit Cholim. They have to be a Beit Refuah. Not a Beit Cholim, they have to be a Beit Refuah. Okay. So I won't go through some of these slides right now, but we make a lot of poor choices, okay? We make poor choices sometimes. And the point of triage, the point of understanding end of life, is to know what is a good choice, what is a bad choice. And not everybody's choices are going to be the same. I always try to discuss with patients and the families, what do they want? Ideally, what does the patient want? These are conversations that the family should be aware of what the patient wants. That is critically important. There is a tremendous gray area in halacha. And Rav Shech the Shlita has written a lot about this, and I've discussed this with him many times. The patient has the authority halachically to decide some of these issues. Again, the 18-year-old boy in the example that I gave you with the traumatic injury does not have a halachic right to say, I don't want any treatment, let me die. That's not a halachic right. You have life. We have an obligation. We have an obligation to continuously try and maintain our health to allow us to serve HaKadosh Baruch Hu. That's our raison d'etre. That's the purpose. It's a little French for my Canadian friends. That is the reason that we live, to serve HaKadosh Baruch Hu. and not to go and have an extra plate of cholent, and not to go to the movies, and not to go and go to the ball game. It's to serve HaKadosh Baruch Hu. And if a person has the ability to serve HaKadosh Baruch Hu, then everything should be done to allow that person to continue. Our definition of quality of life is quite different than the definition the secular society has of quality of life. So that's critically important for us to understand that our choices are going to depend on what that person sometimes wants, in addition to the way that we view, the halacha. And again, different poskim will have different opinions. Rabbi Yashiv was a very, very big kanoi on, even if the patient is suffering under certain situations, you have to do certain things to them. So if somebody's a Talmud, I once had a person that we were taking care of who was a Talmud of Rabbi Yashiv. So we followed Rabbi Yashiv's psak for that person. Somebody else is a Talmud of Rav Moshe, so there's a different approach. My Rebbeim follow the approach of Rav Moshe Feinstein Zatzal, who has written extensively in the Igros Moshe and many other places as to his approach towards end of life. And it's critically important, asay l'cha rav, you as the doctor has to have a rav that you can discuss shilas with, and patients should have a rav. And that rav should be the community rav that knows them. The shilas that are asked to a rav are often dependent upon who the person is. You ask a shaila, a nice simple question, is the chicken kosher, is the chicken not kosher? Well, it sounds like it's straight out. Just look at Shulchan Aruch, what is it possible? And the answer is no. Is the person a rich person? Is the person a poor person? It makes a difference. A rich person, the shaila is no, the chicken's not kosher. A poor person, sometimes, not always, the shaila is the chicken is kosher. You're allowed to take into account their financial status sometimes. You're allowed to take into account shalom bayis issues in regards to a shaila. Should you or should you not take this medication on Shabbos? Should you or should you not be machmir on this hilchos nida question? Well, if that's going to cause a total staring of the shalom bayis in that family, if this is a chronic problem and every time the woman is incapable of going to the mikveh because of some bleeding, so then that's a different shaila than a woman who once time had a question and it's a suffix, yes or no, and you want to be machmir for that woman on the one-time basis. You may be makel for that same exact shaila in a different situation where it's debach, it's staring their shalom bayis. So that's why a rav has to be involved. I just was quoted recently in the Jewish Action, the Orthodox Union newspaper, about ChatGPT and its impact on psak halacha. And this was one of the critical issues that I said that I think at this point in time, at least, ChatGPT is not going to replace Rabbanim. And that is because the Rav has to take into account the entire picture. ChatGPT can take into account every written tshuva. But ChatGPT, at least at this point in time, cannot assess the family situation. No, there's a shalom bayis concern here, that there is a parnasa concern over here, that there are psychological concerns over here, that there are other factors over here that a Rav, an empathetic Rav, a Rav with common sense, a Rav who is a true Rav, who provides a tremendous amount of pastoral care in addition to halachic knowledge, so he has to take into account all of those factors. ChatGPT ain't taking that away so fast. Other areas, beware. But at least I don't think a Rav to Paskin is yet at risk. Now these are general ideas that I like to tell everybody, because these are coming up when we teach people in terms of triage, in terms of how we approach end of life. I think it's critically important that we have respect for everybody. That's respect for our Muslim patients, for our Catholic patients, our Protestant patients, et cetera, et cetera, et cetera. And for our, unfortunately, not yet Shomer Torah Mitzvahs patients, and certainly for patients that are, quote, to our right, right? We're always in the middle, right? There's nobody in this room that isn't in the middle. Everybody's either to the right of you or to the left of you. If I was giving this lecture, this shir, in a different room where people were wearing no yarmulkes or everybody in a kapot and a black hat, they would say the same exact thing. We're in the middle. You guys are off to the left, or you guys are off to the right. So everybody has a centrist position. But we know that there are different positions. And the critical factor in being a good doctor is that you respect whatever your patient is doing. I've had the zuchus, I'll call it the zuchus, to take care of patients that have done many, many things that we would not consider normal part of life as an infectious disease doctor. And patients do all sorts of averis, patients do all sorts of activities that aren't healthy, medically, halachically, and I respect every one of them. And I treat every one of them as a human being, because that's what HaKadosh Baruch Hu wants. Everybody has the tzelem Elokim. Some it's a little bit tarnished, but everybody has the tzelem Elokim. And Rav Shachta Shlita always says that you have to treat every person with tremendous respect. And that includes other colleagues, and it includes all patients. And you treat them with compassion. However, at the same time, we never compromise our beliefs. We never compromise halacha. If a patient says, "I'd like you to pull the plug," I've had enough. I'm 60 years old. I can't golf anymore, and that means I don't want to have a tube in me, even though they're healthy, alert, and oriented. I don't want to undergo this procedure. It's a risk, and I don't want to. So you have to not do anything that halacha says you're not allowed to do. This is one of the commonest shilas that I get from residents and younger doctors. I'm involved in a terminal weaning. A terminal weaning is the very, very nice way we say we're involved in killing a patient. And I hate to use these terms, but it's important because we cloud certain very delicate halachic situations by giving them, euphemisms that are pleasant. A mercy killing. You should die with dignity. You should, be allowed to go the way you want. Well, these are often kineged halacha. So we have to know the right terms. A terminal wean is saying we're going to pull this plug on this person and allow them to die when they are not allowed in halacha to have that plug removed without having that intubation removed from them. So is a resident allowed to write the orders to extubate? Is a resident allowed to be involved in prescribing medications that will cause the terminal death? So the answer to all of these questions is absolutely not. So we have to know. So never compromise what you think is halachically wrong or what you think shouldn't be done. So you can disagree with your patients, but at the same time, we shouldn't be fighting with patients, and we should respect what they want. It's not our job to make every single patient that we see follow the halacha. Where you have that opportunity, I'm often asked the question, "Rabbi, what would you do?" after I had the conversation with them as a doctor. And then I tell them, this is what I think the halacha says. Ask your posek. If you want me to be your posek, I'll be happy to do so. Sometimes they have their own posek, sometimes they don't. Sometimes they'll have their rabbi speak with me, and I'm always happy to do that. I think it's critically important that rabbanim speak with the doctors. And I always like to tell this story as well, that, on Friday night in our shul, everybody comes up to, not everybody, a lot of people come up to, say good Shabbos to the rabbi. And I often get shilas at that point in time because it's a quick shilah. And one of the most frequent questions I get is, "Rabbi, am I allowed to take this medication on Shabbos?" So I always ask them, who are you asking? Are you asking Rabbi Glatt or Dr. Glatt? Because invariably it's an antibiotic. That's because the other stuff is chronic. They're not asking me on Friday night, but they just got they just had bronchitis. They saw the doctor today, and now they're giving their Augmentin or whatever it is that they're giving, and they asked me, "Am I allowed to take this on Shabbos?" So I said, "It depends who you're asking. If you're asking Rabbi Glatt, so Rabbi Glatt will say, if that's what your doctor recommends, it's heter gomer to take it on Shabbos." I said, if you're asking Dr. Glatt, he says it's unnecessary to take that antibiotic, and therefore you can't take it on Tuesday, never mind taking it on Shabbos. So I asked them, who are you asking? So the Rav should be speaking with the doctor. These are extremely complex situations. The game of telephone we used to play as kids, you tell the person in the ear, they tell the next person. The two words at the end of that conversation are far apart. The family's understanding of what the doctor told them then is transmitted to the person who's going to speak to the Rav. As great as the Rav may be, they're going to the Rash Bahag, they're going to the Gadol Adar, he's getting faulty information. And you wonder why the psak isn't right. He was given the wrong information. And sometimes they come to me with the psak of the Rav. I said, there's no way this Rav could have said this. It's just impossible for the Rav to have said that, because I know that Rav, or I know the psak halacha that Rav provides. I said, it's just wrong. Now, call up the Rav and say, did you say this? He said, yes. I said, did you know these are the circumstances? He said, no. So, okay, then my psak is different. So this is critically important. Rabbanim should speak with the doctors. The best person to speak with is there's a doctor in the family that's involved with the nebuch, the sick parent, the sick grandparent. That's the person that should be asking the shaila to the Rav, whether they're a man or a woman. The man is the one that usually asks the Rav the shaila. Okay, but his wife is the doctor, and he's was a businessman, so he has a kesher with the Rav, and he goes to the Rav and misses up on some of the medical information because he doesn't understand the difference between this and that, so he thinks they're all the same. So the Rav then gets a misunderstanding of what's going on and doesn't poskin incorrectly. He poskins 100% correctly for the circumstances that were given to him. But those are unfortunately not the real circumstances. So we have to be very careful about these types of problems. So what's the definition of swimming? Not drowning. And very frequently, these are issues that do come up that people, unfortunately, don't know what to do. And that's why it's so important to try to figure out these things before the person is in that matzah. I unfortunately get these shilas almost every day. Somebody just had a massive stroke. Somebody just had a massive medical emergency, and now what should we do? So my approach in general to these things is, in an emergency situation, you probably should do everything, because we're, again, very, very arrogant sometimes. Oh, this person has 2 days to live. That's never, ever come true. Doctors are terrible, terrible in short-term acute prognostication. We get it wrong all the time. I think it's probably better off flipping a coin. Now, we can say the person's an extremist. We can say this person is very, very sick. We can say that in general, people like this don't do well. But somebody comes in with a massive cerebral bleed, so some of those patients walk out of the hospital. To say day one, DNR, DNI, don't do anything, let them die while you're butchering them, I don't think halachically is right. But this is now week 6, and they haven't never gotten any better from the coma. Now you're talking about, what should we do? Should we be giving aggressive antibiotics every time they get a fever? Should we be doing huge diagnostic workups? So then that's a different shaila. So taking into account the time is, I think, a critical factor in the triage of these patients. And the biggest question is knowing when to let go. It's the most difficult thing to do. It's the most difficult thing to do. People love their loved ones, and they want them so badly to stay with them. And they want them so much to go back to the way that it was. All of us have been in this situation, and I hate to surprise anybody, be a spoiler, we are all going to be on that end of that question one day. At 120, hopefully, I always tell my wife I want to die 120 after I gave the Daf Yomi shir, played basketball, and hit my head on the hoop dunking. That's how I want to go. It doesn't work out that way. But we have to be prepared, Nebuch, for that. And therefore, it's critically important to know, when do we want to say, I don't think halacha sanctions or requires further aggressive therapy, and then what does the patient want? There are those patients that say, I would rather have Yisurim in this world and not have Yisurim in the world to come. And I'd rather go through painful treatments and prolonged life, and that is a halachically valid approach if that's what the patient wants. And there are other patients that say, I don't want the Yisurim and I don't want the schar for them, right? I'd rather not be in pain. I'd rather not suffer. Okay, I'll have to deal with that in the world to come. What HaKadosh Baruch Hu is going to do for me because he didn't get the Yisurim in this world. But that's also a halachically valid approach, and I would dare say that's the more commonly paskin halachic approach amongst the great poskim. And therefore, we have to know what we want to do under what situations, and what factors should we take into account in that. So there are many, many factors that need to be taken into account. And the most critical one that is sometimes neglected is pain and suffering. An individual, Rav Shechter brings down the Rav Yaakov Emden and others that hold that the person has a right to say, I don't want these things to be done for me if they cause significant pain and suffering. Again, not in the 18-year-old. You have to always keep that in mind. When the person has a terminal illness, in Nebuch, we don't have anything to offer for them. If the person has a situation where they unfortunately are going to die no matter what medicine does, and we're dealing here with, is it going to be a couple of weeks earlier, a couple of weeks later, even a couple of months earlier, a couple of months later. But during that period of time, they're going to have significant discomfort, pain, suffering, other factors. They have, to a certain extent, according to most poskim, according to the poskim that I follow, the patient has the right to make certain decisions in that situation for themselves. And Reuven may decide differently than Sarah, and that's okay. Each person can say, this I'm willing to take, that I'm not willing to take. So there are a number of factors over here, but we're running a little bit late, so I'm just going to go through some of these slides real quickly, and maybe I'll even end over here with this slide, and talk about why did HaKadosh Baruch Hu create illness? It's a very good question. Originally, at the time of Adam and Rishon, there was no illness. How did people die? Sneezing. Everybody knows that. And it's so interesting. I had an anthropologist teacher that once said, in every single culture, Jewish, non-Jewish, in the most remote areas of, we have people here from Australia, so in the most remote areas of Australia, in South America, every ethnic group has something like salud or gesundheit if the person sneezes. Why is that? Because it's in our DNA. It's in our history. That it used to be that the neshama would leave the person's body with a sneeze. And until the time of Yaakov Avinu, when Yaakov said it's not good for a person to die suddenly. We have stories, Avraham Avinu said it's not good for a person to die looking young. You don't get proper covered. You have a little gray in your beard, people start standing up for you when you walk in the room. So if I make the beard black, who's going to know to stand up for me, right? So therefore, Avraham Avinu said it's not good for people not to get older looking. So HaKadosh Baruch Hu said, Yasher Koyach, and we'll start with you. And it says that Avram was the first person that became a Zaken. And Yaakov Avinu said, it's not good for a person to die with sneezing, to die suddenly. And why is that? Because they can't take care of their affairs at the end of life. If you're walking around and suddenly, shoo, and that's it. They call the Chayvra Kadisha. So what about the outstanding financial debts that you had? I owed Reuven money, Shimon owes me money. You want to take care of all that for your children. You want to make sure that everybody is going to have an opportunity to say, I'm very sorry for what I did to you. To accept mechila. I accept your apology to me. To put life in order. To give tzavos to the children. Listen, I don't want you two fighting. It's bad enough you fight when I'm around. If you fight when I'm not around, there's not going to be somebody to mediate. There's not going to be somebody to make sure that there's shalom in the family. And et cetera, et cetera, et cetera. And I would spend an entire shir just on this subject alone, but I want to end on this idea that it is critically important that we use the time of Misa the way HaKadosh Baruch Hu said. Yaakov Avinu said, not good to die suddenly, it's good to be sick before you die. And Hashem said, Yasher Koyach, that's a great idea, and we're going to start with you. And it says that Yaakov Avinu was the first person to get sick. And that's why Yosef and Ephraim and Menashe, they came to visit him, and the whole Ma'aseh, Simcha Elokim K'Ephraim Menashe, that's where it all comes from. Because Yaakov Avinu saw that it's a tremendous, the Gemara uses the term Rachmana. HaKadosh Baruch Hu is referred to as the merciful one in that situation, because it's actually merciful that we get sick. None of us want to get sick, but it's actually a chesed that HaKadosh Baruch Hu does with us to give us a chance to put our affairs in order. And if we, so to say, blow it, if we don't use that opportunity, so then all you do is have the sickness and all the suffering without the benefits that HaKadosh Baruch Hu put into people getting sick. So I'll conclude over here. I have many more slides. They're in the slide decks if people want to look at them, where I really go through a lot of the specific therapies. Do you not have to intubate? Do you not have to do CPR? Do you not have to take antibiotics? Do you not have to take dialysis? And you could go through the triage of every single one of these, but there's a simple overriding halachic discussion about each of them that needs to be discussed. Not everybody needs to die with a peg. Not every single person needs to die without having a DNR or a DNI written down to them. You don't have to die having a central line, a peg, intubation, and CPR done on you. That's not what the Torah requires. At the same time, for some people, that is the way that you're supposed to die. So these are all discussions, and extremely important halachic discussions, but just as important, they're family discussions that people need to have, and people need to express to their children, express to their spouses how they would wish their end-of-life time to be, to make it as benign, if that's the right word, to make it as comfortable, to make it as halachically correct as possible. So I'll take questions at this point in time. Yeah.
One thing to mention is that DNR, in a practical sense in Canada, means that if it's written on the chart, a person comes into the hospital, they are ignored by the nurses. There's no treatment, not even, not talking about palliative, but even regular, expected, decent, caring treatment. And that's it, the person doesn't.
So that's a very important point. For those who weren't able to hear the first part of the question, so DNR, I always say, does not mean do not treat. The R doesn't stand for RX. DNR means do not resuscitate. It is a very specific thing not to do. Do not do chest compressions on me if my heart stops. And we stress in our hospital, and I hope that everybody stresses, that a DNR means just that. And we allow and insist that everything up to the DNR be done k'das v'chedin. And that, yes, if they want aggressive pressor therapy, they'll get aggressive pressor therapy. We'll put these people on 5 presses, but we won't do CPR if their heart stops. We'll give them full spectrum, broad spectrum antibiotics to treat an infection, even though if they die of sepsis, we're not going to do CPR on them. So DNR does not mean do not treat. It means do not resuscitate. The R is critical there. And the same thing with DNI, do not intubate. It means that you still give them BiPAP, you give them full respiratory support, you give them high flow oxygen, you give them morphine to make their breathing better. I won't put a tube down you. That's what that means. But everything up to that, if that is what the family wants, if that's what the halacha requires, needs to be done. So these are critically important. And I know people say what you're saying, and it may be true in some situations, but it certainly shouldn't be true, because that's not what DNR means. And the nurses in my hospital certainly understand that. And I think in most hospitals, I can't speak about Canada, I don't know, but in the areas that I have worked in, DNR never meant, at least not nowadays, do not treat. And it needs to be stressed to the families that you have to follow up with the nurses. If you see that things aren't being done the way you want them to, if they're hands-off approach because you wrote a DNR, so then that's wrong. You have to sit down with the doctors, you have to sit down with the nursing staff and say, hey, we didn't say do not treat. We want everything done up to this point. And that's true for every intervention. We want everything done, but we're not going to go on dialysis. That's a very common shaila that comes up. The kidneys are failing. The person's going to die eventually if you don't go on dialysis, but it's not a guarantee at this point that they need dialysis right now. The family doesn't want dialysis. Or they started dialysis and now they want to stop dialysis. So halacha allows each dialysis to be a separate entity. As opposed to intubation, there'll be a share on this, whether there's any way to not continue intubation, but the simple understanding, the way we have it right now, is that once you're intubated, you cannot stop that intubation. You're not allowed to ever pull the plug. Whereas dialysis, each treatment is a separate treatment. So they're going on Monday, Wednesday, Friday for dialysis. So Monday you said yes, Wednesday you said yes, Friday we said no, we don't want it. That's allowed. That's not called withdrawing care. That's called not starting a new episode of care. So there are differences between pressors, antibiotics, dialysis, and many other situations where each one is a separate event. Same thing with a PEG. You put in a PEG and you're giving tube feedings. It's not also to stop the tube feedings. That's not the same thing as a terminal wean. That's not the same thing as extubating somebody. It's saying, I'm not going to put in the next bag of food. Just because you have a PEG doesn't mean you're mechuyev to use it. And maybe, yes, for 3 months, 3 years, we chose to use it. And now, because the situation has changed, we're not going to continue that form of feeding, that form of hydration. So these are shilas that are complex and need to be discussed with the rabbi as well as the physician.
Let's take your question about intubation and extubation. You got someone on a ventilator tube, doing well on 30% oxygen, whatever, desats. Is increasing to 40% a new intervention like a new dialysis?
You're on a certain level of oxygen on the respirator, and the person is now needing more oxygen. Are you obligated, because they're on a respirator, to increase that? And the post can say no. The post can say you're not allowed to decrease the oxygen level. So say that's essentially the equivalent of a terminal wean, according to many posts. Not all, again, not all. There are those posts that say you're allowed to decrease the oxygenation. However, I've discussed it with Shechter Shlita, and I know the opinions of many other great Gedolim. So there are Gedolim that say you can't decrease the oxygen. There are great Gedolim that say you're allowed to decrease the oxygen. So I follow the psak of Rav Shechter in this situation. He was the one I discussed this with initially, and I don't allow them to decrease the oxygenation. However, from a medical point of view, if they were on 80%, and medically we say they're acceptable to go down to 60%, and we lower it to 60%, and they do fine, and then 2 days later they don't do fine, and we would normally bump it up to 80, now you're not mechuyev to go back to 80. And that's a psak from Rav Vosner and Rav Shlomo Zalman. That was a big discussion a number of years ago. So there are different opinions on this. Every person has to go and follow their Rav. But there's a difference between lowering oxygen and removing the tube. According to some, according to others, there is no difference. But everybody would agree in that situation, you're not mechuyev to raise the oxygen up if that is not what the halacha and the family want in that situation.
Said rather strongly, never compromise your beliefs. That sounds pretty strong. What if you are dealing with a patient who's a J witness, who really does not want blood products, and if they don't get blood products, they're going to die? the doctor, of course, has different beliefs.
Well, for the people that will not take blood products. So I'm not getting into the legal parameters. In some jurisdictions in the United States, if they're under the age of 18, they will take that case to court, force the under 18 child to get a blood transfusion, and then give the child back to the parents. I'm not going to get involved in the legal issues. You're not compromising your halachic or ethical position by following the family and not doing something. I'm not mechuyev to walk into every patient's room and say, I disagree with the care that you're getting or that you want, and I'm going to give you this treatment no matter what. That's illegal. You can't do that. I express my opinion to the family. I think you should be getting blood products. You're bleeding out. You've had a traumatic accident. You have a medical problem that would normally 100% of the physicians would give you blood products. And they say, no, I don't want to take blood products. Assuming they're an adult, assuming there are no legal options or considerations to do. So then we follow that person's viewpoint, at least in the United States. Now, I'm not talking about the times of a Beis Din and a Sanhedrin where things would be different. I'm talking about practically in the Eretz Yisrael or in the United States or in Canada. You can't go against the patient's wishes if they want that. But that's not compromising your views. You're not doing something. They're not letting you do what you would like to do, as opposed to, I'm going to extubate you. I'm consciously doing something that goes against what I think is halachically correct. That you're not allowed to do. So there's a big difference between shevi al taseh and taseh and doing. So I could not go and extubate that person because that's what the family wants. But I'm not mechuyev to intubate them, even though I think halacha would say that they should be intubated if the family's not letting me intubate them. So that's not going against they're just not letting me do what I would like to do. That's okay. With the exception of my wife, nobody else lets me do what I want to do all the time. Yes?
Well, I have two questions. I still don't exactly understand the difference between what you explained in the beginning about giving fluids and not giving somebody fluids and doing what they call a terminal wean on a ventilator. I still don't understand. One case you're deciding one thing, the other case you're deciding against it. But the other thing I think a lot of yeah. Okay.
Withholding a therapy versus stopping something that is already in existence. That's a critical factor in halacha. In secular ethics, and incidentally, I worked at Catholic hospitals all my life, this is their opinion, it's not our opinion. They don't always distinguish between withholding and stopping something. So in Catholic tradition or in secular ethics, they don't make such a distinction. They say, well, if you wouldn't intubate them, you're allowed to extubate them. Halacha disagrees with that. Halacha says you're not mechuyev to intubate every single person. But once somebody's intubated, if you remove that tube, so then you have essentially killed them. Now, you may have killed a person who was a goses. You may have killed a person that was terminally ill. Technically, you wouldn't get misas beis din for that, even if you got hasra, and you were warned, and you said, I'm doing it anyway, because the person technically doesn't meet misas beis din qualifications. But you're still a rotzeach, maybe with a good heart. And how HaKadosh Baruch Hu is going to judge you is not my issue, but I can only tell you what the halacha is. The halacha says you're not allowed to go and do that. Whereas, not putting in the tube, you're not a rotzeach. Halacha says you don't have to put in the tube. So that's a critical factor in halacha. Stopping an already existing therapy versus not doing that therapy in the first place. Halacha makes a huge distinction between those two. And therefore, to stop somebody from giving them fluids, so if it's medically contraindicated, of course you stop it. But if it's not medically contraindicated, you let the bag run out, you're not mechuyev to put in the next bag of fluids. That's a new action. That's not called stopping fluids. It's not starting a new bag of fluids. That's a different halachic approach than saying, I'm going to stop the presses they're on. So when we halachically, I tell patients, you're not mechuyev to continue to give presses. So I say, let the bag run out that's running in, and just don't put in another bag. And that is halachically acceptable where it's halachically acceptable. Whereas to stop this, to turn off the presses that are going in, and that's going to cause that patient to die, those presses are giving them the circulatory support that they need, and I turn off that switch, I plug that IV, and suddenly the patient's going to drop their blood pressure, then I have actively killed that patient. But to not put the next bag in, halacha allows that.
My second question is, I think a lot of the controversies that I've encountered has to do with, and their opinion I respect, it has to do with interaction with nursing staff, especially in the ICU. Nursing staff is with patients, 24/7. Doctors are not in with patients 24/7. Often the family's not with the patient, and they often have a distinct view in terms of what their treatment is, what they're asked to do, etc. And especially where I treat, they have great influence. Maybe they should, maybe they shouldn't, but I don't know how you deal with when you say, well, I think we have to continue the treatment maybe because of what you're saying, and maybe what the family is saying, and what they're saying because they're intimately involved with the patient.
I'll flippantly answer your question, and I'll tell you the real answer. The flippant answer is a box of donuts. The best thing that you can do to make sure that the nurses take care of your loved ones is to bring them food. A box of donuts, Pop-Ems. This way they're individual, they take a little one, they're all on diets, so give them a little one.
Nurses in our hospital won't be buying off by donuts, let me tell you.
Well, what I'm saying is to maintain a very good relationship with the nurses and to recognize the tremendous hard work that they do. So that's the easy, flippant answer. The real answer is, yes, you have to do that, but the nurses have to understand that it's not within their purview of what they're entitled to do or not do to make those types of decisions. And those are only decisions that a physician can make with the agreement and with the company of the family. And therefore, nurses do not have the right to say we're not giving pressors. Nurses do not have the right to say that we are giving pressors. Those are decisions that the nurses are supposed to be carrying out the wishes of the family and the orders of the doctor. It's not within their purview of practice. This is a legal term. They are not allowed to make those decisions. We often abdicate those decisions to them, and they're often highly qualified. An ICU nurse who's been there for 20 years knows an awful lot more than the intern on service that month. But at the same time, they shouldn't be making these decisions. They're entitled to speak with the doctors, speak with the family. They're entitled to give their opinion. But ultimately, it's not their decision. And I want to give equal time to Rabbi Brody, so I'll thank you very much for listening.
Thank you very much, Rabbi Glatt, for a very enlightening discussion. I think we probably could have spent some more time on this and maybe have an open session tomorrow. There will be a session which will be, there will be two sessions tomorrow I want to point out. One will be discussing some medical issues, medical cases that we are going to ask the panel, and some of these topics are going to be addressed. And then, of course, tomorrow at Sudash Lishit, at Shalosh Shudas, there is an open Q&A. So that's always an opportunity to be able to catch up a little bit. While we're setting up over here, Rabbi Brody will be now discussing organ donation. I hope you had an opportunity to, we have the project renewal. And if anybody, people familiar with the organization, it's a wonderful organization based in the United States. There's a Canadian branch. There's a branch in Toronto specifically, and really they make it a point about live organ donation. So that's a different topic than we're going to be discussing right now. Right now we're going to be discussing the broader topic of organ donation from the various different ones. But I encourage you, if you have an opportunity over Shabbos, to be able to reach out, speak, find out a little bit about organ donation. Tomorrow, Rabbi Steinberg will be co-hosting one with Rabbi Jaffet not tomorrow, this afternoon at 2:30 on live organ donation. So this is really a wonderful opportunity. But for now, I'm going to turn over to Rabbi Brody, who will be discussing the much broader topics of organ donation in general. Rabbi Brody.
Okay. So Rabbi Steinberg is going to be speaking about respiratory brain death and organ donation. Shkoyach. Thank you. On after brain death, and there'll be live discussion. I'm actually talking about the future and the non-known present of organ donation, and I want to explain what I mean by that. So the title is When Death Becomes Reversible: Medical Innovations, Time of Death, and Organ Donation in the 21st Century. And I'm stressing this is a 21st century conversation, not the 20th century conversation. What I mean is, we're all familiar with the great debate, machloket, etc. I'm not going to say who's who, because it's a debate about who says what, right? About the issues of brain death and organ donation. I'm talking about what's going on now, the innovations which are probably not even many people aren't aware of, and what the future might bring, and what halacha might have to say about these questions. Okay, so no conflicts of interest here of grants, and we're going to try to understand the new ethical dilemmas and appreciate potential Jewish approaches. So, my friends, even if you're not American, but you'll be familiar with Benjamin Franklin, who at the time of the founding of the United States says, our new Constitution is now established and has an appearance that promises permanency, but in this world nothing can be said to be certain except death and taxes. Now, given what's going on in the United States and other countries around the world, I can tell you I'm not so sure that the Constitution is going to last. And given what I'm about to show you right now, I'm not sure that death is going to last, but I can assure you that taxes will always be with us. So I don't know if this is a up wave starting or a down wave starting this year, but let's just put that in perspective. And here is what seems to be the future. So you might have seen this in last summer. This is findings I think Nature magazine wrote it up, but it was widely reported, where pig organs were partially revived in dead animals. And what they did was they killed pigs, waited an hour after cardiac arrest, and then threw in a tremendous amount of blood substitutes, which was comprised of animals' blood and various compounds, and got organs to start renew their vitality. An hour after the pigs are dead, by all definitions, by all appearances, right? They then use this blood substitute and get organ vitality going again. Remarkable. And by the way, this is a couple of years after the same group had done something similar after brain death. In fact, that case was 4 hours. So what the future seems to bring, or bear, could be, we don't know, right? But what seems to promise is that we're going to have a situation in which people are dead. By any definition that we know of what death might be, which is normally, how do we define death? No, before you get to that, what is the one thing we always say which makes death so difficult? It's irreversible. And suddenly, what does this mean when the criterion that we usually think of what is death is suddenly now reversible? Is that meaningful? Do we care about it? Does that change the status of this organism being alive or dead when you can now reverse what we thought was the irreversible cessation of a various type of function? And now all of this is already going on, but we should understand that while this might be a bare future, and scientists are talking about those issues greatly, right? But the issue of organ donation today in the Lamasseh, in Canada, in the United States, and everywhere in the West but Israel, I'll explain to you why not but Israel, is that there's many new times when organ donation is happening. So traditionally in the world that we live in, we think about organ donation as what's known as DBD, right? Donation after brain death, okay? But in many places around the world, between 25 to 45% of the cases of organ donation are actually happening after DCD. Donation after, we'll call it for now cardiac death, although we'll see why we should be calling it circulatory death. We'll come back to this. Okay? And what the donation after cardiac death protocol allows for is there are times when there's cardiac death that occurs, and we can retrieve some organs then. There's a protocol, we'll discuss momentarily which organs, which allows. Now, when I first learned about this, I'm like, oh, this is amazing, because this will end all of the halachic issues, right? Because we have all this debate about time of death, brain death, not. Everyone agrees cardiac death is halachic death. That would be great. But the problem is that in the vast majority of countries and cases right now, DCD is happening in what we call a controlled circumstance, CDCD. And in CDCD, the way we're doing this is withdrawing care, which Rabbi Glatt was referring to beforehand. Let's say removing a respirator, waiting for cardiac death, and then immediately you're retrieving organs. Now that's, on the one hand, is after death, but according to halacha, which we'll discuss other times, is problematic because you are hastening the death or causing the death. But this is going on already. And so it depends where you are and which hospitals in different places. In Southern California, it's about 25% of organ donations. In Northern California, it's about 45% of organ donations. In England, it's almost 50% of organ donations right now are coming from DCD. Now, historically, meaning as of 12 years ago, right? We're talking really new stuff. This was not possible to retrieve a heart. More or less, wasn't possible. Of course, was a shortage of hearts. And so part of the techniques and protocols which were being developed now says, well, maybe we can manipulate the situation in a way in which we can pull the plug, but in a way in which we can create cardiac death, listen to this out, then immediately stop brain circulation to the brain by closing off blood circulation to the brain, and then getting the heart to start again. You got it? You got cardiac death. You then cut off the line so to make sure that there's not going to be any restored circulation to the brain, which then it causes brain death. And then you get the heart beating again. Pretty crazy, right? And then you start to ask yourself, well, what just happened here? You withdrew care to get the heart to stop. Then you cut off the circular lines so that way you don't get the brain going again. And then what do? Get the heart going again. Forget about the question whether you've killed someone or not. Is this person dead? Because what did you declare the person to be dead with originally? Their heart stopped. Then you say, no, we're going to brain death. And then we're getting the heart going again. Is this a good thing or a bad thing? Well, it allows us to retrieve hearts. So you could say that's good. And it allows us to retrieve hearts in cases where a decision has been made beforehand to declare that continued medical intervention is no longer appropriate or necessary, and therefore we'll withdraw it. So you could say, we're now just manipulating the situation in a way where they're going to die anyway. Let us allow some life to come from this. But you understand you're playing a lot of games with what's death. How are we defining this? And of course, as with all medical innovation, I say all, but with many cases of medical innovation, what's going on in the hospitals is faster than the law can catch up to it, which is an interesting phenomenon in its own right. And so there's a major, now I'm highlighting this machine for a minute, right, as part of the method, because I want to understand this is questions of how we use technology. Now, if you look at the ECMO, right, it's amazing. ECMO is amazing. It's amazing. Just acknowledge that. It's amazing we live in an era where we have machines like this. But raises tremendous amount of questions about how we use technology ethically or not. And so there is a major statement from the American College of Physicians in April 2021 where they basically said what you are doing, i.e. transplant doctors, is wrong. Because you're playing around with the definition of death in ways which are so manipulative that it starts to raise questions about what used to be the classic standard of organ donation, namely the dead donor rule. We do not take organs from someone who's not dead. Period. That is the standard rule, or has been the standard rule. And what the American College of Physicians are saying is once you start this, the procedures and operative definitions used to determine death seem orchestrated to serve that end. Loss of circulation wasn't irreversible. How do you know it wasn't irreversible? Because you got it going again. So how can you say, right, you are orchestrating a death? The intent, however, is to reinitiate circulation. And the patient is, in fact, successfully resuscitated. But they'll say back, yes, but in the meantime, they're brain dead. Answer, you manipulated that brain death. How did you manipulate that brain death? Because you prevented brain reperfusion when circulation is restored. The purpose seems to justify reversing what was supposed to be irreversible. Are they right? So in response, a number of ethicists who are in defense of this method have said the following. Said, listen, what we care about isn't the fact that we got the heart beating again. What we really care about is not the heart, but the function of the heart. And they say as follows: the irreversibility as defined is the function of the organ within that person. During NRP-C DCD, right, controlled donation after circulatory death, the organ's inability to function within the organism was confirmed with the determination of death. And here now they get into the question of intent. There is an important difference between resuscitation with the intent to alter the ultimate outcome and the use of extracorporeal circulation to perfuse organs. Right? Intent matters in these circumstances, and therefore we can declare death because there is not the irreversible cessation, but permanent. Now this is a machloket. This is a disagreement even within cities. So for example, if you go to New York City and you go to a Columbia hospital, where Ken Prager's there and Lydia Dugdale's there, they won't do this. You go down to NYU, they're doing it. By the way, just understand, as a side, the motivations here about saving lives and what's ethical. But you know how much money you get paid for every heart transplant? So it's a massive amount of financial and economic repercussions to this question, which they're doing at NYU, but not doing at Columbia. Now, part of this discussion, of course, is this distinction between irreversible and permanent meaningful or not? And you understand that what's going on right now is the ways that we can manipulate and change and alter what happens with which organs stop and how they function, and whether we can get them going again in a manner which they'll be vital but not restore full functioning has become a critical definition. And the question becomes, right, does halacha have anything to say about this? So this is not from a book by Rabbi Shlomo Brody. This is actually a book from Rabbi Shlomo Goren. But I was doing this as I got into a plane and I was typing something else. So please, I don't want to take away of Goren's credit here. I was writing a number of different shiurim and articles at the time. So Rabbi Shlomo Goren, I noticed this morning, made a very interesting distinction already in the 80s. And he says there's a difference between a heart and a heart. What is the difference between a heart and a heart? There are trei dinim in a heart, right, if you want to use lumdisha terms. There's a heart which has a functional purpose, and there's a heart which is biological organ. Death occurs when the heart no longer functions for circulation. The fact that you can get the cardiac element, right, the organ, going again, revitalize that vitality is irrelevant. The heart only matters, is significant when it's causing a full amount of functionality. Does this point to an argument which says that this would be a definition of death which we can accept? Maybe, of course, if you don't have to ask the questions of manipulating the process. And so we have to start asking again, as we've been doing for many years already, what is death? Okay, because right now you understand we are playing around with the body in a way in which this notion of irreversibility, which always seemed to be what death is now very questioned. And the technology is getting more and more powerful to question this. So, death, is it a moment or a process? So here you have two different figures who have very different positions, as is well known, on the issue of brainstem death, right, and organ donation. Rabbi Bleich Shlita on one side, Rabbi Steinberg Shlita on the other side, and both of us will tell us the same thing, though. Death is a process. Meaning the death definition, and therefore the definition of death, let's see from Rabbi Bleich, cannot be derived from medical facts or scientific investigation alone. Science will tell us how the organism, right, will stop working, will describe to us in general about the physiological state, but the determination when you say a person has died in that process of dying is going to be ethical, religious, cultural, whatever it might be, but the scientists can only tell us so much in terms of describing what's happening to the organism. So let me give you an example. If you have flowers on your table from last Shabbos, you forgot to get rid of them. You come home on Sunday, and they're sort of, are they dead, are they not dead, there's water, but they're dead. The answer is, who cares? Right? In other words, we don't really care. You decide, you throw out the flowers today, tomorrow, whatever it might be. But you understand that you could argue, right? You could see people in the family arguing. Are they dead? Are they not dead? Who didn't put the water in, right? May or may not happen in my house, right? Etc. But we don't really care. With humans, of course, we care. We care a lot. And not only do we care a lot because of the Tzelem Elokim that we care about, making sure that we keep people alive and don't kill people, but also because of the implications of organ donation. So we know that halacha has a moment of death. How do we know that halacha has a moment of death? What halachic concept tells us that halacha has a moment of death? Tuma and Tara. We know that someone's dead. When someone is dead, right, then they become metameh. But there's always been a little bit of this question, right? How do we know exactly if a person is dead? So this was not always a perfect process. If you look in the Mishnah and Smachot, they have a number of stories. It once happened that a man who was buried was examined and found to be living, and he lived for another 25 years. And they talk about even waiting a few days, and the Shulchan Aruch brings down the question about whether we can always know when a person is dead or alive. This has not always been a perfect process. If you really want great bedtime reading, I recommend a book called Buried Alive. It is as it sounds, okay? And it's a book about the great fear over many centuries of people being buried alive. But don't worry about this, except for just to note that in both New York and Indiana this year, people woke up in the morgues. Which only means to tell you that this hasn't always been a perfect process. But I don't want you to worry about this, really. Meaning, we understand that this hasn't always been a perfect process, but we've been able to know when a person is dead. I know when I see it. Now, has halacha been concerned about this? Not so much, because we understand when a person is dead. My famous beloved line of the Chidah, if in one of many tens of thousands of cases it happens that he's alive, does it not devolve upon us to slay his transgression? For so it has been decreed upon him. Meaning, v'kach nigzar alav, meaning if we accidentally buried someone alive, you know why we did that? He was chayiv misa anyway. I don't think the Chidah would have cut it as the pulpit rabbi. Can you imagine the Proba Shabbat? Rabbi Azulai, what would you say to a family if we accidentally bury their loved one alive? Have no fear, he's chayiv misa anyway. No way he's getting the job. Okay, but you understand, but in general, right, there is this understanding that we've understood what death is and can see it. Now, the problem is, what happens with technology today? Technology has transformed this question. So Professor Stein will get into all the discussions about the test that gets into the Gemara and Yuma, has this famous question. You find someone, you're not sure they're dead or alive. They're not responsive. What do we do? What does halacha say? The feather test. The feather test, as brought down the halacha Shulchan Aruch. There's a big machloket, though. And by the way, it's very interesting. If you look in the Shulchan Aruch Rav, his formulation here is very interesting. He says there, Ikar hekar chiyutu b'chotem. He indicates to us that it's not just a test, but the criteria for what it means to be deaf is the element of whether or not you can see breathing in the nostrils. And this became, of course, the big fight. Do we accept respiratory brain death as halachic definition of death or not? Do we learn from this Gemara, which gives us the feather test, that we also have a criterion for death? And that criterion for death is the cessation of respiration, the irreversible cessation of respiration. Rabbi Moshe Feinstein, at least according to his son-in-law of Moshe David Tendler, accepted this definition, and others did not. With Zilberstein, for example, being representative of saying to the fact that it's only a test for death if there's no signs of life. But if the heart is still beating, there's a sign of life. To which Rav Moshe said in response, no, right? Even if the fact that there's a sign of life because the person's heartbeat is still going, the criterion for death is the irreversible cessation of respiration. By the way, fun fact, where does Rav Moshe write this fact? Everyone always says it's from the Igros Moshe, right? Because that's where his Chuvas are published. Not true. It was republished in the Igros Moshe. In 1976, when Rav Moshe wrote this Chuva, it was sent out to every member of the Association of Orthodox Jewish Scientists, with an English translation and 5 pages and an explanation from Rav Moshe David Tendler, his son-in-law. Which means that if this wasn't his position, and he had changed his mind or didn't mean it, you might have expected that to have been clarified in the forthcoming newsletter, which it wasn't. But nonetheless, there's a big dispute about it. I don't want to get into this issue. And therefore, but here's the point. It was irreversible. It was irreversible cessation of respiration. The chief rabbinate and every single religious Zionist rabbi in Israel have accepted the irreversible cessation of respiration as the halachic criterion for death. It's the only thing that religious Zionist rabbis actually agree upon. Which is a pella, except for a positive, right? What do we do in Shemitah? What do we do in Kashrus? What do we do on Geirus? Women's issues, army issues. Religious Zionist rabbis can't agree upon anything except for this issue, which is really remarkable. In the Haredi world, in practice, no one holds of it. They do not accept the respiratory brain death. And in the Chutz La'aretz, it's a big fight. And no one wants to talk about it. Okay, now, I don't want to get into this issue because Professor Stein is going to talk about it later. What I want to discuss now is the following. What happens when all this discussion becomes moot because it's not irreversible? When everything becomes reversible. Do we have any precedents to talk about this? So I saw here this famous story of Elisha and his resuscitation. What exactly was going on in this story? Remember the story in Malachim? Right? He picks up the child and brings it to the mother. The boy seems to be dead for a while. He leans over him and what? Resuscitates him. So some people love to say, oh, we had it first. As we had in Tanakh, he did CPR, this or that. Is this CPR? No, I don't think so. I mean, I know some people love saying that. I think this is what we call a miracle. Right? In other words, like, I don't know. Maybe this story is, maybe it's not. But I don't know. I don't like reading it that way. So I don't have much to learn from this. But there's a very interesting question to think about. Person, what happened to this boy? Let's say this boy wasn't a boy. He's married. Okay? So he's married. And his heart is stopped for 30 minutes, 40 minutes, whatever it might be. 20 minutes, doesn't matter. He gets resuscitated, hops off the bed. Does he have to get remarried? After all, how does a person marriage stop? Two ways, divorce or death. So this is the great shaila known as, is there wife after death? Right? Is the wife after death? Because if you think about it, wait a minute, he was dead or wasn't dead. So this actually was asked as a shaila in the 60s. It's really fascinating, 60s or 70s. And it was actually by a Kiruv rabbi who wanted to ask certain things, like maybe this proves that there is life after death. And from that discussion got into the debate about whether there is wife after death. Okay? And it turns out it may even be a machloket, which is sort of awkward, but in general, we understand today that certainly we don't consider that 20 minutes or 10 minutes or 5 minutes when the heart wasn't beating that the person was dead. Why not? Because it wasn't irreversible. We might have thought at the moment it was, but then it turned out to be not the case. So the fact that we found out afterwards it wasn't irreversible means that they're not dead. So the question then becomes is, what happens if the technology allows everything to be reversible? Which doesn't mean we're going to do it, but we could do it. Because we could perfuse the body in this way in order to get a heart beating again. But the question, of course, would be for what? For what purpose? But again, it's not irreversible. It might be permanent loss of circulatory function. It might be permanent loss of respiration. But you are able to get the organs vital and going again. Because nothing anymore is irreversible. It's a scary thought in some ways. Right? On the one hand, we hate death because death is irreversible. So this should make us happy. But this isn't what we had in mind when we wanted death to be reversible. When we want death to be reversible, what do we want it to be? We go back to normal. We hop off the bed like the boy with Elisha. this ain't what we wanted. And so now we have this tremendously powerful technology, right, to fuse organs in a way to restore vitality, but not in the way that we wanted it to be. So what happens then? Do we even have a moment of death anymore in such a world? And of course, you have to ask as well, what has happened with the world of organ donation? Because again, even if you hold, and this is very interesting to keep in mind, by the way, I mentioned there's something called controlled donation after cardiac death. There's also something called UDCD, uncontrolled donation after cardiac, or let's call it circulatory death. This is being done primarily in Spain and in France, but in other places as well, various experimentation with it, in which they have situations where in an uncontrolled manner, we're able, right, we have a case of cardiac death, and organ donation is possible in those circumstances. In fact, in the living will, which we're going to be showing you in the next session later today, a Matthias living will tells people you have an option to donate after death has been declared by the criteria of Jewish law. Why did I formulate it that way? Not just because I wanted to avoid the brain death debate, but because I think the next 10, 20 years, whatever it might be, donation after cardiac death in an uncontrolled manner is going to be greatly possible, which is going to open the door for a tremendous amount of halachic donation, but it won't open any door if everything's reversible. So should it matter? So let me ask you the following question. Can we sacrifice our chaye shah, our last moments of what we would call life or suffix life, in order to save others? In general, can we sacrifice our life to save others? It's a very fascinating question. Let me give you the following scenario. Suppose you have a gosses. Everyone agrees the gosses is alive, but someone who's clearly in the dying process, maybe the last day or 2 days, let's say it's even the death rattle. Right? We have a real feeling this is going to happen. And you're in Soroka Hospital, and let's call the patient Roi. And you're in Soroka Hospital in Beersheba, you got 8 people around, you got the mom, you got the dad, the siblings, you got 2 doctors, 2 nurses, and they're all sitting there waiting to stand be the present when the person dies, or Marie dies, and suddenly a grenade is thrown into the room. And there's nowhere to run to. But someone says, Roi's a gosses. He's going to die anyway. Let's throw his body on the grenade to save the rest of us. Would you do it? Would you do it?
No.
What if Roi in his lifetime had said, if I'm a gosses and a grenade is thrown in the room and I can save 8 people, throw my body onto the grenade. Would you do it?
Allah says no.
Would it be? I think Allah says it's mutter.
Roi did.
Of course. So who's the Roi I'm talking about? Roi Klein. Threw his body on the grenade in the Second Lebanon War. Save his comrades. I think it's mutter. And so if that's the case, right? If that's the case, you start to ask yourself questions, right? Can you save, right? Sacrifice the terminally ill to save others? Because remember, the case of this deaf person might not be irreversibly dead, but there's a permanent loss of total functioning. So you're in this limbo zone, which is even much worse. Would we allow it in that case? But you understand, friends, if I start making the argument that we can save the lives, we can sacrifice the lives of the terminally ill to save others, where am I going with this? You know where I'm going with this?
Medical assisted.
No, I'm going to Canada.
Oh, that's what I meant.
Because every year in Canada now, there are over 50 cases of euthanasia organ donation. Person's not terminally ill, suffering greatly. And he says, I want euthanasia and I want my organs to be taken. I literally just got this question from someone in Yerushalayim who's got Alzheimer's, who wrote me. I know you're involved a little bit in the world of organ donation, which actually my organization is much more focused on broader end-of-life issues, but he asked me, I want to do euthanasia in Israel and donate my organs. Now, Israel doesn't do DCD, donation after cardiac death, and we don't do euthanasia. So I said to him, I sent it back to a social worker I work with, mental health professional. But you understand that if you start making these arguments that we don't know when death is, but we can sacrifice, well, where do you draw the line? It's a very dangerous argument, which is why I'm very, very hesitant to make such a claim. Which then brings us to our question, though. Nonetheless, could we say that even if we're in this middle zone, we have a suffix whether the person's alive, because they're not irreversibly dead, could we sacrifice them for the sake of others? So this argument actually was made by Moshe Sternbach. Moshe Sternbach is the head of the Eidach Haredis. There's no chashash that he's been somehow corrupted by modern values. They're the Eidach Haredis. And Moshe Sternbach asked the following question. When it comes to this issue of defining the moment of death, why does it matter? After all, if a person is brainstem dead, for example, they're clearly in the category of a gosses. We can say we can sacrifice the life of a gosses in order to save others. It's very fascinating. I made that argument. He doesn't take this to l'maaseh, but he says, mutar lo limso et chayav latzalat chavero. If that's the case, and we continue to create all these in-between gray zones, is a person dead or alive, and it's well beyond the questions of brainstem death now, could we say, well, in those cases, can we limit it? Now, Shlomo Zalman Auerbach Zatzal didn't like this idea one bit. Shlomo Zalman Auerbach said, no, we do not sacrifice that way and allow people to sacrifice. And so you have to ask doctors to cause the death of a suffix. Either we've got someone's dead or he's not dead. We can't be in this limbo zone. In fact, to the point, and this is the least followed psak of Shlomo Zalman Auerbach, the least followed psak of Shlomo Zalman Auerbach was that you cannot not only donate organs in Israel, but you can't even receive organs in Israel. No one holds this psak in every direction. But why? Because he said, if we don't think this person is dead, we can't support a system that promotes that definition of death, which doesn't follow halacha. Shlomo Zalman wanted a clear definition of death one way or the other. And then the question now becomes which is very intuitive to me. I would like to have a moment of death. But what happens when science is making everything reversible? In some sense, but not in other senses. This is going to be the great dilemma of the next bunch of years. Because the organ donation debate that we know and love, right, from the 60s and onwards, which is still going on, which is still very relevant, the D family, right, it's all very relevant today, but is slowly but surely going to be transformed as the technology changes and we can revitalize organs and revitalize the body in a certain way well after any definition of classical definition of death. And the technology is basically already here. And it's only going to be developed more. And it's going to be developed more because we have a real incentive, a good incentive in some ways, in order to save lives by increasing the number of organ transplants. But look what the American College of Physicians was saying. You're playing around with the definition of death. And friends, I'll end with this thought. I'll take a few questions. But as always, the technology is advancing faster than the ethics and the law. And so if we're not thinking about these questions, we're going to wake up the next day, and all of a sudden, death has been transformed. Maybe it's a good thing, maybe it's a bad thing, but we should be thinking about it. And im lo achshav, imatai. Questions? Oh, microphone.
So, questions of donor aside, are we allowed to approve the use of an organ from a made donor? Or it could get even worse. In China, they use organs from executed prisoners. If the organ is procured that way, can we accept it?
Yeah, so this is a major issue. So the Chinese case came up because of someone I'm friendly with, who's a transplant doctor in Sheba Hospital, Jay Lavi, had a patient come to visit him. And the patient said to him, Jay, I'm getting a heart in 3 weeks. So Jay says to him, that's not exactly how it works. He says, no, I'm going to China. My insurance is paying for it. And I'm getting a heart. And that's what he did. So Jay started looking into it. And he realized that the Chinese were killing political dissidents, Falun Gong and others, and then giving their hearts. And Israelis were going there because they want to live. And so Jay made a big tumult about it. He's written about it. And Rabbi Yosef, to his great credit, came out and said, this is absolutely usser. Even though we all want you to live, you can't go to China in order to get an organ when it's been done by killing someone. What's fascinating is that Rabbi Yosef initially seems, at least he told Dr. Abraham, that he agreed with Rav Shlomo Zalman that in Israel, where we can have some influence over the system, you can't receive an organ after brain death there as well. And then there's this famous case where a young teenager who needed an organ went to Rabbi Yosef and said, I don't want to take an organ if this is usser. And Rabbi Yosef said, no, you can take it, it's mutter. The question is why? How do you reconcile those two psakim? Because he thinks it's usser to do it in the case of China, but he doesn't think it's usser when you are suffix killing him, according if you don't accept brainstem death in a regular DBD case. I think the answer intuitively somehow relates to this. When we have a suffix dead person, when the person is permanent, right, damage, right, permanent loss of respiration, which may no longer be irreversible, but is, at least according to today's medicine, still irreversible, he'd allow people, if they're going to do it anyway, for you to take it. But you understand that once you start saying that we're going to allow other people's definitions of death in order to, and then accept that to take organs, that gets very tricky. And so when you're in Canada and you need an organ now, and you know that there are going to be numerous cases a year, which is only going to increase, where this was done through euthanasia, it raises a lot of questions. And so if you don't have this notion of allowing self-sacrifice in order to save others, I think it raises a lot of ethical issues. So I'm not answering your question because I'm not sure yet what to do with that.
It's a whole spectrum. Is that it is self-sacrifice. If you go to India and you bought a kidney from someone who's willing to sell it, it's just still on the spectrum of self-sacrifice. They're not doing it out of any altruistic reasons. They're doing it because it's the only way they live.
Right. You understand? Yeah. The point you're making is excellent, and it raises the question when we're manipulating bodies for the sake of transplantation, which is amazing, right? Because we can give the gift of life. It's incredible. But as the technology keeps on developing, we're going to be getting ourselves into very, very difficult questions. Which is why I would like to be in a position where we can say we have a definitive moment of death. That's where I want to be, because we can draw a line and preserve the dead donor rule. I believe in the dead donor rule. I just don't know if science is going to let me have that anymore. Yeah, pass the mic. Is there a question, even when a person is declared dead, according to everybody's definition, but you can revitalize organs, is there any issue of defiling the dead? So, in general, defiling the dead is always a question. Right? We don't normally, would not manipulate a corpse in this way. But if they're dead and they can save a life, pikuach nefesh is docha the isurim of nivol hamet or hanat hamet or halan hametim even. Right? So that's a critical point. It's true, we normally would not allow us to, this is the whole issue of autopsies and medical study, right? In general, we don't allow the benefit of a corpse in this manner. This is a little bit more complicated than I'm making out to be, but that's a general rule, of course. But here you have a sakanas lefanenu, right? You have a person in front of us. There's always, when it comes to organs, a need. Someone has a need for that organ. So that's why that would be mutter in that case. If you think the person is dead. If you think the person is dead. If you don't think the person is dead, you're in tricky grounds. You're in a tricky spot. Does that require pre-mortem consent by the person who has died? So this is interesting. Who defines death? Because in pluralistic societies, when people can have multiple connotations of one is death, you get into questions. Well, if this person thinks that they're dead, but you don't think they're dead, but they think they're dead, does that matter or not? Those who don't accept respiratory brain death according to halacha, which are many great poskim like this, many great poskim who I greatly respect, don't accept it, but they say that you can still receive organs because they say the person has decided for themselves that this is the definition of death. Society accepts it. If they're going to declare themselves dead, you can still take their organ. That is the argument that is made in order why you can take but not give. Next question. There's another. Yes.
I thought this is a problem when they're doing massive organ sharing in Europe and in Israel. And Israel was very keen to receive organs, but not keen on donating organs. Right. And therefore, then they decided maybe not to share with Israel to get organs. Right. So is that now...
Israel was kicked out of the European Sharing Network because Israel was taking too many organs but not giving enough. The organ donation rate in Israel has gone up. So it's about 56% agree to donate organs after brain death, which is a real improvement, but it's still much lower than the rest of the Western world. Okay, now, you understand that Israel doesn't do donation after cardiac death because of all these issues and withdrawing care, which means that the number of organs available in Israel is inherently going to be limited for two reasons. A, you have large segments of the population that don't accept brain death, and B, you don't have donation after cardiac death. So one of the things I've been working on a little bit on the side is to try to get Israel to start following the Spanish and French model, to try to explore cases of uncontrolled donation after cardiac death. But it's complicated. There are a lot of complicated issues with it as well, both ethical and other reasons as well. But that is going to be the issue in Israel. And Israel is going to have a shortage of organs, except that Israel has the highest per capita rate of live donation, of kidney donation, altruistic donation. And so there's a lot of organ transplantation going on in Israel because of people donating their kidneys. And since kidneys are the number one organ that's needed, it's about 85% of the organs that are needed, that helps reduce the list overall. And so if you want to solve the problem, if you want to try to increase the number of organs being donated in Israel, your best method is going to be to increase the number of live kidney donations going on because of various reasons that donation after death is much harder to achieve in Israel. Yeah?
Can you explain what you mean when you say Israel doesn't allow donations after cardiac death? Because certainly they allow kidneys and cornea and everything after a person has died.
Sorry, I should be clear about that. Israel doesn't have DCD protocol, which means that they'll allow corneas to be donated or heart valves to be donated. But in terms of the life-saving organs that we're talking about here, kidneys and livers, this or that, which is done by the CDCD, the controlled donation after cardiac death, Israel doesn't have because the Israeli law forbids withdrawing treatment in a manner that will lead to immediate death. And the only way you can do this, because organ donation is such a sensitive, time-sensitive process, is by doing it in a very controlled manner. Because if you don't do it in a controlled manner, the organs won't be vital anymore and be no good for retrieval. And so since Israeli law is actually, this is the one law in Israel which actually follows halakha. Meaning, it's very fascinating. People think, like the marriage law in Israel and divorce and not selling pork and whatever it is, none of this stops any isurim going on. Right? Nothing. You don't let someone get married, they break up? No, they go to Cyprus or they just live together. And you don't let people, sell chametz in public. Did people stop eating chametz? No, there's something called freezers, right? In other words, all these things got to buy. This is the only law in Israel which is actually governed by halacha after a 59-member committee led by Professor Steinberg came up with a law on the terminally ill. And one of the things that came up with is you can't pull the plug. If you can't pull the plug, you can't have controlled donation after cardiac death in general. We'll see. Again, the technology is amazing. So it's going to raise all sorts of questions, but it might destroy the dead donor rule. Are we happy about that or not? I feel like I'm ending all of my lectures on a very depressing note. So let me just highlight the fact that this technology is amazing. It's amazing. We just need to think about this in a profound manner and try to work this out. Try to use technology in ways that are ethically and halachically sound, which is doable in my mind.
This is an issue which can be thought through. We can address this issue if we're aware of it and willing to confront it. And that I actually think is a positive message, because it's very exciting. Right? We're on the frontier, and we should be on the frontier. And if we combine our powers as rabbis and doctors and caring citizens and whatnot, we can address the pressing ethical issues of our time. Thank you very much.